As part of our monthly AARP-sponsored segment that highlights issues important to older adults in Arizona, we look tonight at a new acute care unit at Banner University Medical Center in Phoenix that focuses on reducing the length of time that older patients stay in the hospital. We learn more from Dr. Nimit Agarwal. He's medical director at the Banner Center for Healthy Aging, and Susan Dimfeld. She's a nurse navigator for the unit. Good to have you both here. Thanks for joining us.
Thank you.
Thank you.
Doctor, we'll start with you. The Acute Care for Elders Unit, what is that?
So really, this is a program which looks at patients not just from a disease perspective, but we're also really focusing on something specific to like mobility, mentation. When patients come into the hospital, they can get confined in bed because we're concerned they might fall. But that may not be best for them. It's really important that nurses, physicians are looking at, they're walking in the hospital so that they don't lose function. And when they leave the hospital, they actually get back to driving or whatever they were doing. And that's the focus that we are trying to create with this Acute Care for Elders unit at Banner University.
And how does that differ from traditional care?
So traditional care is very focused on disease management. Here, what we are doing is adding elements of care, for example, looking at mentation, mobility, what matters to our patients in a very dedicated, standardized fashion, training our nursing staff, training our therapists, training our pharmacists, physicians, on making sure those elements of care are check marked on every single patient and not just on a case-by-case basis.
And Susan, you're here because you're a nurse navigator at the unit. What does that mean?
So I'm the geriatric nurse navigator. So that means my role is to support not only the nursing staff, therapists, the people taking care of the patients, but also help patients and their families know, particularly the families know what they can do to support their elders while they're hospitalized.
Compare that to the work you've done in the past.
Oh gosh. Well, for me, it was very different.
Yes.
I had done a lot of administrative and program building things, and I really hadn't been at the bedside in a very long time. So for me, it was very eye-opening to see the changes, particularly post-COVID, the challenges that all hospitals and really everywhere that provides care has. So I was the nurse navigator, and then both my parents ended up being patients on the unit.
I was going to say, how did that work out? Because talk about if there's ever serendipity to be hospitalized, that would probably be it.
Yeah, or your personal life colliding with your professional life. Besides being kind of weird at the beginning, it was very relieving for me because I knew what needed to be done. I knew that there were expert geriatrician hospitalists that would be able to look at my parents and know those specific things they needed. They're in their 90s. And particularly my father was hospitalized first with a broken hip, and he has dementia. And so his confusion became more so hospitalized. And I was able to put into the place all the things we preach all the time to the families. Come stay with your loved one, bring their hearing aids, their glasses. Just be there 24/7. And it was so important with my father. He would wake up, forget he had had surgery, try to get out of bed, and then we were like, oh, Daddy, no, it's okay, what do you need? And then oh, you're there? Okay, then he'd go back to sleep. So it was real hand. I got to see what it was that Dr. Agarwal is so passionate about.
Is that a typical story that you hear, especially when it comes to dementia, delirium, these sorts of things which may or may not be found in more traditional care?
Absolutely. So delirium is missed more than 70% of the time, sometimes by physicians, 30% time by nurses. And it's really a dangerous syndrome because it can affect lifelong challenges with function. It can cause problems like patients who are driving in the community can't go back to driving after hospitalization. So it really affects their life. Using common sense approaches, having family be there with their family members. Patients with dementia, for example, they're really dependent on their caregiver, their family member. If you break that diet, that can cause challenges for patients. Just like for Susan's dad and mom, who were in the hospital, they know Susan. But when I come as a separate person, as a doctor, they may not know me very well. But when Susan holds their hand, it really brings a different kind of care, a different kind of outcome for patients like this.
Yeah, and you mentioned earlier mobility and things like this. Falls, so important for older folks. the impact of this kind of care on that?
Absolutely. If you are mobilizing, even one single day in the hospital, if you're not mobilizing, if you're laying in bed, that will cause loss of muscle function. Especially for older patients who already have a little bit of risk, this becomes even more important that we don't lose even that single hour when they're maybe getting out of bed into the chair, eating their meals, getting out for a walk. If we don't do those things, that will have long-term outcomes for increased risk for falls, increased risk for needing for walking aids or something like that. So those kind of challenges can occur.
And Susan, that all rings a bell with you, I would imagine.
Yes, yes. Exactly. No, it was my parents, who were both hospitalized in the spring and summer, then were able in early August to celebrate their 70th wedding anniversary together with us, and then have Christmas together despite both of them having a couple of hospitalizations. So being able to be in the unit and receiving that care really allowed them to go back to their to where they lived and carry on with life.
Which is the goal. Last question real quickly here. Geriatric care in general, is it evolving?
It is evolving. We have a new concept called age-friendly health systems, really focusing on what matters to the patient. We're not looking at the patient anymore, we're looking at the person as a whole. We are making sure that what matters connect to their function through mobility and their mentation, cognition. How does that affect? Medications that we are using, we're making sure they're not harmful for that mentation as well as mobility. And we connect to what matters. Find the person in our patient. That is what we are focusing on in geriatric medicine.
Dr. Nimit Agarwal, again, Banner Center for Healthy Aging, Susan Dimphil, a nurse navigator at the center. Good to have you both here. Thank you so much for joining us.
Thank you so much, Ted.